I'm a consultant ophthalmologist for the Manchester Royal Eye Hospital and a professor of ophthalmology and retinal regeneration for the University of Manchester. I've been working in ophthalmology for 23 years now, always with an interest not only in clinical care but in research in new therapies. Well, the Manchester Royal Eye Hospital is one of the oldest eye hospitals in the world. The Manchester Royal Eye Hospital was founded in 1814 as a dedicated eye hospital. We are a teaching institution. We are affiliated to the University of Manchester, and we are very proud about this link. OCT technology, or optical coherence tomography technology, has evolved significantly over the last 15 years. I've started using optical coherence tomography in ophthalmology in 1998. At that time, we were using time domain technology. We then moved on to Fourier domain technology and now on to swept source technology. OCT is strongly linked nowadays with Topcon as a company. Topcon introduced the first Fourier domain system back in 2006. It was the first system with 3D rendering software. Now Topcon has introduced swept source OCT technology. The product is called DRI OCT1 Atlantis. The main differences with Fourier domain technology is that DRI OCT1 Atlantis uses longer wavelength, 1050 nanometers versus 850 nanometers. Faster scanning, 100,000 A-line scans per second. We obtain very long scans, 12 millimeter scans, opposite to 6 millimeter scans. This allows for gives us a significant advantage when scanning the back of the eye, the posterior pole, because in a single image we not only can assess the macula but also the optic nerve. The faster scanning, the longer wavelength allow for uniform image quality, allows for minimal eye movement because of the use of infrared light. The faster scanning, the infrared light, allow for less light scattering and better penetration through opaque media, for example cataracts or an opaque vitreous. The longer wavelength also allows for visualization of the choroid. We can even image the anterior surface of the sclera for the first time in a very detailed way. The resolution has increased. And also, very importantly, for the first time, we can clinically document and assess the cortical vitreous. The cortical vitreous is an elusive structure, if I can call it like that, in the eye. It's difficult to visualize with slit lamp by microscopy. There are some publications on the anatomy of the vitreous with slit lamp by microscopy. Most of our knowledge of the cortical vitreous comes from post-mortem specimens that have been stained either with milk or special dyes. Now with the Atlantis OCT system, for the first time we can image these structures in vivo. We think that for the first time we are seeing the invisible not only in the vitreous but also in the outer retina and in the choroid. It is going to be important to move to swept source OCTs because most of the treatments now being developed or a significant proportion of new treatments being developed are going to be administered via intravitreal injections. It is therefore imperative to know the anatomy of the vitreous, because it may have an impact on the response or non-response to certain therapies. We are already aware of the role of vitreomacular adhesions and vitreomacular traction in several conditions like diabetic macular edema, central retinal vein occlusion, macular hole, symptomatic vitreomacular attachments. So it is going to be important in the future to image not only the retina to say whether there's intra or subretinal fluid present. This is not enough at present. We will also, or we do need to image at present the cortical vitreous and the choroid. One of the most important advantages of DRI over EDI is that opposite to EDI, DRI allows for the visualization with excellent image quality across the image, not only of the vitreous, but of the retina, the choroid, and the anterior surface of the sclera in a single image. You don't have to concentrate either on the vitreous or on the choroid. You get an image with good quality extending from the vitreous, cortical vitreous, to the anterior surface of the sclera in a single frame. Swept source technology is going to be very important for the assessment of the vitreoretinal interface. It is only with swept source OCT that we can reliably assess the cortical vitreous and confidently say whether a bursa premacularis is present, whether the cortical vitreous looks normal or not. We can pick up perhaps a higher percentage of vitreomacular attachments with swept source OCT than with Fourier domain technology. Also, when we try to scan myopic eyes, short-sighted eyes, swept source OCT becomes very important because it allows for excellent image quality from the vitreous to the choroid in a repeatable way. When we were first acquainted with the Atlantis system, we started looking at the neuroretina, of course, looking as to whether we could easily image the presence of intra or subretinal fluid, the presence of an intact layer of inner and outer segments of photoreceptors, which is what we are trying to do with Fourier domain technology. However, we quickly realized that there was much more that we could see with the Atlantis OCT, and we, for the first time, we could see a bursa premacularis in vivo very clearly. We were very excited about this finding, and even more excited when we could find bursa premacularis in other patients. So that led us to believe that the Atlantis OCT could be very useful for imaging the cortical vitreous. We started a study looking at the cortical vitreous of patients. We looked at 117 consecutive scans, and we started comparing our results with what's been published in the literature. Seminal work on the cortical vitreous has been published by Worst, who in 1975 described the presence of the bursa premacularis, and then he described the presence of a system of cisterns in the cortical vitreous. We've been able to show with our research that the bursa premacularis is not a result of aging of the vitreous, but that the bursa premacularis can be present also in young patients. We've imaged with the Atlantis OCT patients as young as 5. We think that with DRI OCT1 Atlantis, it is easier to diagnose the presence of retinal tubules in patients with chronic age-related macular degeneration. It is important to differentiate the presence of tubules from that of intraretinal fluid in the outer retina, because retinal tubules are not an indication for treatment. I think the DRI OCT1 Atlantis is going to have a significant impact on everyday practice. Not only because of the image quality, not only because we can see the vitreous, we can see the choroid, but because it's a very user-friendly system. It takes seconds to obtain a scan. It's got a small footprint, so it is possible to move the system within rooms in an institution. It allows for deep penetration of ocular structures. We can penetrate through hemorrhages, thin retinal hemorrhages in the macula, to assess the status of the choroid and the outer retina. Very importantly, for the first time, we're able to objectively assess the cortical vitreous and the vitreoretinal interface. It allows for very long scans, 12mm scans compared to 6mm scans. So in a single scan, you not only image the macula, but you can also image the disc. The infrared light also allows for minimum eye movement, and minimum eye movement allows for better image quality. The combination of very fast scanning, 100,000 A-line scans per second with infrared light, very importantly, allow for good uniform image quality, not only in the retina, in the neuroretina, but also in the cortical vitreous and the sclera, or the choroid up to the surface of the sclera. I think as we move more and more towards intravitreal injections-based treatments, it is going to be important to study the cortical vitreous, know the state of the cortical vitreous prior to starting treatment, know the state of the cortical vitreous during treatment and after treatment, as the status of the vitreous may have an impact on the response to different therapies. It is going to be more and more important to image these structures in a non-invasive way.